fix through a catheter, the other a comprehensive, durable solution built with anatomical precision. One promises comfort while the other promises completeness. It began in the late 1970s when balloon angioplasty first challenged bypass surgery. As PCI evolved, first with bare metal stents, then with drug eluting stents, and now with physiology guided strategies, it started encroaching upon the territory once firmly held by CABG, multivessel disease, diabetic patients, and left main involvement. Each iteration brought a new trial, new comparison, and a new attempt to declare equivalence between each other. And each time CABG was asked to prove itself again, not just in the OR, but on paper with endpoints and p values. But if we read closely, we'll see that these trials weren't always fighting fair. Different rules and sometimes different truths. Today, we are not just here to interpret the p values, we're here to question their context. We're not here to choose who is winning, we are here to draw the examination of the battleground. How was it? Who wrote the rules and what it really tells us about the patient care? And to help us through that, we have Dr. Prabit Narayan, who has written critical appraisals of these trials. All of us who have performed or trained in CABG know its completeness, the relief it brings, and the durability it offers, and the outcomes we witness with our own eyes. But in today's academic world, it is not enough to be clinically correct. We must also be scientifically precise. Our convictions must align with evidence, our reasoning must hold under scrutiny. When we sit at the OPD convincing our patients, we need to know the bare truth of these scientific evidences. Dr. Pradeep has tried to voice out that reason through several of his critical appraisal of trials. In an era where randomized trials are often taken at face value, his papers have consistently asked the uncomfortable questions. Is the endpoints appropriate? Was the comparison fair? What was left unsaid in the fine print? Now let us get to know in the discussions ahead. It all began with the syntax trial, a landmark study that compared PCI and CABG in patients with complete complex triple vessel disease or left main disease. Syntax clearly demonstrated that CABG was superior, especially in terms of long-term outcomes and freedom from repeat interventions. It was the first real evidence that validated the durability and completeness of surgical revascularization. But the story didn't stop here. With newer drug-eluting stents, notably the everolimus, came the best trial, an attempt to see whether the modern PCI could narrow the long-standing gap with CABG. While CABG remained superior in terms of myocardial infarction and repeat revascularization, these trials subtly suggested that PCI was not far behind, positioning it as a reasonable alternative, especially if one was willing to accept a few more reinterventions over time. With PCI, it was first physiology. The FAME trial instead introduced refined lesion selection for PCI by identifying blockages that truly caused ischemia. This was a major step forward, fewer stents and fewer events. But that was PCI versus PCI. The natural next question was, can this stand up to CABG? And so arrived the FAME 3 trial. The FFR guidance, modern stents, hand-picked patients. PCI was given its best shot, yet despite all innovation, CABG still prevailed. FAME 3 could not demonstrate non-inferiority. MI and repeat revascularization were significantly higher in PCI arm. Now we will discuss these trials in brief. While I quote some salient features of these trials, Dr. Pradeep has agreed to discuss what the trial is actually trying to say. The syntax trial was a landmark RCT that compared PCI using paclitaxel eluting stents versus CABG in patients with complex coronary artery disease, the triple vessel or the left main. It established CABG superiority in patients with high anatomical complexity with syntax score greater than 33, while PCI was acceptable in low score patients. It also introduced a syntax scoring system to guide revascularization strategy and emphasized the need for heart team decision making in complex coronary artery diseases. The results were at 1 year, PCI had higher major adverse cardiovascular events than CABG, which was 17 versus 12.4%, mainly due to repeat revascularizations. Stroke was more frequent with CABG with 2.2% versus 0.6 in PCI, while death and MI was almost similar. By 3 years, CABG was significant lower MACE rates, fewer MIs, and fewer repeat reinterventions. This advantage persisted at 5 years, with CABG showing lower MACE rates at 26% versus 37%, MI at 3.8% versus 9.7% in PCI, and mortality 5.8% in CABG and 9.6% in PCI. Stroke rates remained slightly higher in CABG but were not statistically significant. At 10 years, the all-cause mortality was lower with CABG with 24% versus 27% in PCI. In triple vessel disease, CABG had a clear mortality benefit of 21% versus 28% in PCI, while the outcomes were similar in left main. PCI had more repeat revascularization and faced higher subsequent risks. So, based on the trial, I'd like to ask some pertinent questions. Can you give us any more clarity on the syntax trial?
Yeah. So, Karan, can I just quickly share my screen?
Sure, sir. Sure.
It'll be just easier to explain.
Sure.
So I hope you can see my screen now.
Yes, sir.
And you can probably see my slides as well. Can you see the slides?
Yes, sir.
Okay. So see, first things, I think Syntax was a very good trial. And the cardiologist told us that Syntax was a very good trial at the end of 1 year. But as the results after 3 years and 5 years started coming, they started hating Syntax trial because the results did not show what they wanted it to show. Now, as far as the evidence from Syntax trial is concerned, it is very, very overwhelming. And whatever we do, whatever the guidelines say today, most of them are based on the Syntax trial. So Karan has already talked about it. I just want to highlight few things that you have to just remember from the Syntax trial. And I'm only talking about the Syntax 10-year data, because once you have 10-year data, what happened in 1 year and 5 years really doesn't make too much of a difference. So if we look at the 10-year data, one thing was very obvious, that in high Syntax score and in triple vessel disease, these two conditions, CABG was superior to PCI. Okay, you can see on my screen these two things. So clearly, if you have a patient who has got triple vessel disease and who has a Syntax score more than 33, CABG is a better option. There is no doubt about it. The second point which we have to remember is what happens if you have a left main stem disease? So Syntax trial did not show any difference. That's the first one. I have not highlighted it, but it's the first one in this chart. And it shows no statistically significant difference between PCI and CABG. So those are the 3 points you have to remember. The fourth point you have to remember from the Syntax trial is what happens when you've got poor ejection fraction. So this is a Syntax sub-study. So they identified all the patients who had ejection fraction less than 40% and did a subgroup analysis to see what it showed. And it showed, you can see from the survival graphs, that people who had CABG had the incidence of events was much lower. And it was concluded that the p-value is just borderline significant, 0.05. And the authors themselves concluded that in patients with impaired LV ejection fraction, CABG seems to be safer than PCI. Now, we have to also understand one thing, that left main stem disease and poor ejection fraction, these were not the initial intention of the study. The study was only powered for major events. Despite that, when we looked at left main, it showed no difference. When we looked at poor ejection fraction, it showed that CABG was borderline significant. What it means is, if we carried out a study with more people, these differences may become very apparent. So I think syntax was very useful from that point of view. And these are the four things you have to remember, that in high syntax score and in triple vessel disease, CABG is superior at 10 years. Left main, there is no difference. And in poor ejection fraction, there is borderline significance. Thank you, Karan. You can continue.
Yes, sir. In this trial, sir, only 41% of screened patients were ultimately randomized in the syntax trial. Do you think this selective enrollment left out more complex cases where it would have been more benefit for the CABG?
Yeah, you are absolutely right. So, but still, I would say that the recruitment, see, what does it imply? That 40% of the population was suitable for the trial. So it was not a study that can be applicable to 100% of the patients. But as far as trials go, I would still say Syntax had a higher recruitment. If you look at the best trial, for example, which I know you are coming to later, the recruitment was only 20%. So Syntax, you are absolutely right. If more people were included, more complex cases were included, then CABG would probably, the difference would be even more pronounced. But despite only 40% being recruited, there was still a significant difference.
Yes, sir. So the reported stroke risk with CABG, even though it is just 2.6%, it has always been challenged for its superiority based on that. Do you feel the stroke risk is always overstated in interpretation while the protection against MI and mortality tends to be underappreciated?
Yeah, see, in fact, when I started by saying that the 1 year result, the cardiologists actually they told us this was the mother of all trials, like mother of all battles, and that PCI was superior to CABG, and this was decided only because the stroke rate was significantly higher with CABG at 1 year. But at 3 years and 5 years and 10 years, there was no difference in the stroke rate. So we know that CABG can cause higher stroke rates in the beginning, but it evens out as we go along. So effectively, see, I keep on saying that once a 10-year trial data is published, there is no point harping about the 1 year data. The 1 year
Okay.
data was valid at 1 year, not at 10 years. So 10 years, there is no difference in stroke rate.
Yes, sir.
One question, Pradeep.
Yes,
Did
sir.
these did these patients include off-pump and on-pump cases? And when you have a no-touch technique for the aorta?
Sir, the proportion was very, very low. I don't think there were many patients who had a no-touch technique. You are absolutely right. If you do a no-touch technique, then the stroke rate will be even lower. But this was a real life sort of situation. And in Europe, still 80% of the patients in Europe and in the US are operated using on pump. So, I mean, it would be a bit unfair also to say that we should only compare them with total arterial revascularization with a no touch technique. It was a real life sort of representation.
Okay. Okay, Karan, go ahead.
So the next trial was the best trial in 2009. This was of bypass versus everolimus, while the paclitaxel test was the syntax trial. It was an international randomized study comparing PCI with everolimus stents to CABG in patients with multivessel coronary artery disease. Total of 880 eligible patients were enrolled with a median follow-up of almost 11.8 years. The PCI group received an average of 3.4 stents, while the CABG group received 3.1 grafts, with nearly all patients receiving a Lima to LAD. The primary endpoint was composite of death, myocardial infarction, or target vessel revascularization. The best trial compared PCI with everolimus stent, and it compared over 12 years. The primary outcome was death, MI, or target vessel revascularization, similar between PCI and CABG. 34% for PCI and 30% for CABG, with no statistical difference. The all-cause mortality was also similar, of 20.5% for PCI and 19.9% for CABG. However, PCI had significantly more spontaneous MI, with 7.1% compared to 3.8 in CABG, and repeat revascularization of 22% compared to 12% in CABG. Overall, major adverse risk were higher in PCI, which was 44% versus 35.1%. So, coming to the discussion of the trial, despite the superficial clarity of the trial, we see that your critical appraisal paper talks a little bit in depth. Can you please let us know what we are missing in this trial?
Yeah, so I'll just share my screen again. There are just 2 points which I want to make in this. You have already covered most of the things, Karan. I just want to show just these 2 points. So, first of all, we have already talked about earlier that only 20% of the people who were screened were actually included in the study. So it is a very, very sanitized sort of patient selection. They don't represent true patient selection. And it will become very obvious if you look at these two criteria. So the coronary diameter, because these patients had to be suitable for PCI as well as CABG, the coronary diameter had to be at least 2 millimeters. Now, all of you just think, when was the last time you saw a patient with a 2 millimeter coronary artery?
Exactly.
So, I mean, imagine if they had chosen real life patients. If they had chosen patients who had 1.5, 1.25, what would happen? That's the first thing. The second thing is, I'm glad we spoke about the syntax score earlier. So the syntax score already showed that the benefit of CABG lies in high syntax scores. Here, the mean syntax score was only 24. So what it means is 5 out of 6 patients had low or intermediate scores, where CABG is known not to provide a benefit. So the patient selection was such that almost 85% of the patients were supposed to have no difference. And despite that, there was a difference. So see, there was a difference in the MACE events, but they have not talked about it. They have talked about if you read the paper, they talk about composite outcome of death, MI, and stroke. Here they have excluded re-interventions. But if you look at re-interventions and spontaneous MI, in both the cases, CABG was significantly better. So the point here is the BEST trial is a fantastic trial, but it was overtly sanitized, does not reflect real life practice. I mean, I can't remember when was, last time anybody saw a 2 millimeter vessel and a low syntax score. And despite that, CABG had better revascularization need and had lower spontaneous MI. So that is where the BEST trial, shows that CABG is far superior. And those are the 2 important points to remember. Thank you, Karan.
Yes, sir. Also, sir,
One question.
Yes, sir.
No, so that means we hardly ever see a 2 millimeter vessel. So
Yeah.
these data may not be extrapolated to the Indian scenario.
Absolutely not, sir. Absolutely not. In fact, this data cannot be extrapolated to even this was carried out in South Korea, in the South Korean population, because their native coronary arteries are equally small. And that is the reason why they could not include 80% of the patients they screened.
Okay.
It was a very difficult trial to recruit. They only recruited 20% of the patients they screened, which is also remarkable that they found 20% of people had coronaries more than 2 millimeter in size.
Okay.
another thing about this, sir, a significant proportion of these PCI patients received IVUS guidance. Is it fair to interpret these results as
Yeah,
reflective of
see,
average
you are
global?
right. You are right. But I don't worry too much about those things. It is like we were discussing earlier on that what happened if we did total revascularization, total arterial revascularization, no touch technique. Of course, your stroke rate will be low. If you use IVUS, then of course, you'll be grafting vessels in a more objective fashion. But I wouldn't worry about it. Despite all those things, this is what the results are, that CABG led to less reintervention and less myocardial infarction. I mean, why do we have CABG? So that we don't have any problems in the future.
Next, we go on to the FAME trial. This was published in 2009. It was a multi-center randomized study that enrolled 1,000 patients with multi-coronary artery disease. It compared outcomes between the FFR-guided PCI, where only lesions with FFR less than 0.8 were stented, and traditional angiography-guided PCI. The objective was to determine whether tailoring PCI based on physiological significance rather than just visual severity could improve the outcomes in multivessel disease. Before we get into the results, let us understand the concept of fractional flow reserve. The FFR guided PCI represents a major evolution in the precision of their coronary revascularization. Unlike traditional angiography, which evaluates the anatomical severity of coronary stenosis, the FFR measures the physiological impact of that narrowing, especially whether it truly limits blood flow enough to cause ischemia or not. This is done by calculating the pressure gradient across a lesion during maximal hyperemia. Hyperemia, which is a state of maximal vasodilation, electively induced using intravenous adenosine. The value of this FFR lies in its ability to distinguish which lesions are genuinely requiring interventions. This is defined as the ratio of blood pressure beyond a coronary narrowing to the pressure in the aorta during the state of maximal hyperemia. This is artificially induced state of maximum coronary blood flow by vasodilators like adenosine or papaverine. It provides a reliable, quantifiable indicator whether a lesion is truly ischemia producing. FFR value of less than 0.8 identifies a functionally significant lesion, one that is likely to cause symptoms or myocardial damage and should be treated. In contrast, lesions with FFR greater than 0.8 can often be safely deferred, even if it appears severe on angiography. This principle is crucial because many lesions that look tight on imaging may not actually compromise the blood flow. Stenting them unnecessarily exposes the patients to procedural risks and long-term complications. Here is an example of the use of this FFR. In the panel A, we see coronary angiogram showing narrowing in two side branches, OM1 and OM2. Visually, both appear deceased, that is ostial OM1 here and diffuse OM2. And without further assessment, we might be tempted to either graft both of the OMs. When we move on to this panel B, where this FFR measurements tells us the physiological truth, the pressure tracing shows that OM1 has a reading of 0.97, meaning the flow is adequate and the lesion is not functionally significant. In contrast, the OM2 has a value of 0.68, confirming that there is ischemia producing and needs a reintervention. Following this, a targeted stent is placed in OM2 as seen in this figure. OM1 is left untouched because the guided value does not require us to intervene unnecessarily. Finally, in this panel D, we reassess the both vessels. Post PCI, the OM2 is now 1.0 in FFR value and the OM1 remains at 0.95, both indicating excellent blood flow. The pressure curves have flattened, signifying successful PCI with no residual ischemia. And with this, the FAME trial provided compelling evidence that the FFR-guided PCI was better than angiography-guided PCI in patients with multivessel coronary artery disease. The visual data is consistent reduction across all major cardiovascular outcomes when PCI is guided by this fractional flow reserve. The composite endpoint of major adverse cardiac events was reduced by 30% with the guidance. The reduction was driven significantly and declines both in MI and repeat revascularizations, reduced by about 30 to 35% compared to angiography decision making. The benefit was most dramatic in death rates, where this guidance of PCI showed an approximate 40% reduction, which is 1.8% versus 3% in angiography. These physiological innovations indeed refined PCI strategies and improved outcomes within its own domain, but the real test came when it stepped forward with FAME-3 trials, aiming to compare these advancements against the time-tested gold standard of CABG. Conducted across 48 international sites, the trial randomized 1,500 patients to either the guided PCI or CABG, with median follow-up of 3 years. And primary endpoint was composite death, MI, or stroke. At the end of the study, the fractional flow reserve guided PCI failed to demonstrate any non-inferiority to CABG. Although death and stroke rates were similar between the groups, PCI associated with significantly higher rates of myocardial infarction and repeat revascularization. The composite endpoint of death, MI, stroke, and reintervention were also notably higher in the PCI arm. Interestingly, outcomes were comparable in patients with low functional syntax scores, but CABG showed clear advantage in those with more complex disease. In essence, the fractional flow reserve has elevated the precision of PCI. FAME3 reaffirmed the CABG superiority in providing long-term durability and protection, especially in anatomically complex cases. Coming to the trial discussion, sir, FAME3 excluded patients with left main and complex comorbidities. Do you think this selection bias titled study population towards lower risk PCI candidates as such?
Yeah, absolutely. See, we know one thing for sure, and that is why I'm so happy that we have already discussed the syntax trial, and I'll keep going back to the syntax trial because the more I'm reading the literature, the more I feel that our entire practice is guided by the syntax trial. So we know that if there is a complex coronary lesion, CABG is better. That's a proven fact. So if you exclude those patients, the benefit is definitely not going to be there. So I think this study was again designed to favor PCI, but there is much more in the FAME trial. And I'll just, share again some of my slides. I mean, just
Sure.
2 or 3 I've prepared. So let me just share it. So you can see my screen again. And so I'll just give you a very brief summary of trials using FFR. You have already covered it, but I just want to, summarize it. See, the FAME1 and FAME2 had nothing to do with CABG. For exams, at least, that is what you have to remember. FAME1 and FAME2 had nothing to do with CABG at all. FAME1 was simply PCI with FFR and compared PCI without FFR. So naked eye assessment of lesions and assessment with FFR, which Karan showed very nicely that it can be very different. And it showed that FFR reduced unnecessary stent insertion. So that is all you have to remember from FAME1. FAME2 was optimal medical therapy versus FFR guided PCI. Again, see, this is where the importance of FFR is there. When PCI was guided by FFR, it provided better outcomes with optimal medical therapy. If you look at all the other studies that have been done, the ischemia trial or the orbiter trial, there was no difference between PCI and optimal medical therapy. And this is where FAME2 was better than them because here PCI was guided by FFR. They were only putting stents in lesions that needed a stent. And then we finally came to FAME3. FAME3, obviously because PCI was better than optimal medical therapy, they wanted to prove that it is better than PCI as well. But FAME3, which is basically a non-inferiority trial. So what they're trying to show is not PCI is same as CABG or PCI is better than CABG. They were trying to show that FFR guided PCI is not inferior to CABG. Now, these terms, when we talk about the language, may seem the same, but they are not the same. How do they differ? A non-inferiority trial will require very few patients. An equivalence trial will need even more. And a superiority trial will need even more number of patients. So most of the PCI versus CABG studies that you'll read, you'll find that they have written it's a non-inferiority trial. So it starts by accepting CABG as a gold standard, and they try to prove that FFR guided PCI is not inferior to is non-inferior to CABG. This is what the studies are. But when they write about it, they say that FFR guided PCI was similar to CABG. But you cannot say that. you have to say that was non-inferior to CABG. Because when you say that it was similar to CABG, you are pretending that this study was an equivalence trial. Anyway, I think I have bored you enough with the equivalence, non-inferiority and superiority trials. The 1-year study results showed that FFR guided PCI was not founded to be non-inferior. Now, again, I'm sorry, but I have to explain this to you. In the English language, when you say not non-inferior, because there are two negatives, it automatically becomes inferior. Not non-inferior, two negatives, so it becomes inferior. But statistically, it's not. We'll ignore that. We'll also ignore the 1-year data because now the 5-year data of the FAME trial has been published. So let us take a look at the 5-year data. Okay. And Karan, you said 3 years, but actually it is 5 years has already also been published. It was published last month, I think.
Yes, sir.
So see, what they have done is a small trick. The primary composite endpoint here, I've highlighted it in yellow. Look at the yellow one. It says death from any cause, stroke or myocardial infarction. So this is the primary endpoint they have studied in FAME 3 in the 5-year follow-up data. And that shows there is no difference. You can look at the p-value, it is 0.27. They have not provided any other p-value here. But if you read FAME 1, you'll find that their initial objective was death, the one I have highlighted at the bottom, death, myocardial infarction, stroke, or repeat revascularization. In this paper, they have removed repeat revascularization. And they had to remove it because if you look at the actual objective with which FAME trial was started, the FAME trial shows that there was a significant difference. I don't know if you remember it from my last sort of discussion, that here the hazard ratio is 1.44, and if you look at the confidence interval, it does not include 1. So it shows a significant difference. So you can see that even a journal like Lancet allowed this to be published. So you start the study saying that your objective is death, myocardial infarction, stroke, and repeat revascularization. When the 5-year data comes, you remove repeat revascularization, and you only talk about death, stroke, and MI. I mean, that is unethical. They have provided the data for death, MI, stroke, and repeat revascularization, but it is people would have forgotten what the primary outcome was in the FAME, trial in the 1-year data. So this is very, very unethical. I even sort of wrote a letter to Lancet, which I don't think they are going to publish. So that's one thing, that FAME, even though it shows that it is no different, there was a trickery involved here. And the second important point to remember is, think of syntax trial again. If you follow the journey of syntax trial, you'll find that at 5 years, syntax trial did not show any difference between PCI and CABG. But at 10 years, CABG was found to be superior. So the second point you have to remember is this is only 5-year data. And most studies which compare PCI and CABG do not show a difference at 5 years. They only show a difference at 10 years. And I'm very confident that FAME 3 will never publish its 10-year data. That's all. Thank you. Karan, over to you.
Yes, sir.
You have any other questions on this?
Not on this, sir. And this. Yeah. So PCI brought almost different things to the battleground, like different stents, different drug stents, and now the physiology guided stents. Should we now look inward, how we as surgeons innovate and evolve? We have seen PCI progress rapidly, and we have 3 questions. Where does CABG stand today despite modern PCI? How surgical revascularizations can evolve? Is there any technique change, training, trial design? And what innovations can happen? Would the total arterial or a minimal CABG hybrid strategies, what may shape its future? Also, a big question, so many research and clinical trials are going on with PCI, but why not with CABG itself? Why don't we see a large number trial being published?
Yeah, I
Good
mean,
question.
you've asked a lot of questions.
Yes.
So, see, you tell me one thing. How many trials have been done to see if the patency of Lima to LED is good? Practically,
Hardly, sir.
there are no randomized control trials that has ever been done to show the superiority of Lima to LED. It's only from one retrospective study by Floyd Loop.
Yeah.
Point I'm trying to make is something that really works. You don't need clinical trials for those. So if you look at the inception of clinical trials, they are designed when there is a clinical equipoise, when we don't know which is better. You will not find, see, there are more than 100 trials that have compared PCI and CABG. And there is not a single trial that has said that PCI is superior to CABG at any time point. So CABG remains the gold standard. Now, as far as CABG evolving is concerned, yes, of course we can evolve. Of course we should evolve, and we are evolving. So there has been a current push in two main areas. One is increased number of arterial grafting and minimally invasive techniques. Now, I feel that using more arteries is good, but you also have to be very judicious. More arteries translate into better outcome only if they are used appropriately. Otherwise, veins are good enough. Patency of, and there is a lot of work that has happened in the area of venous grafts as well. There are a lot of studies now which have shown that the patency of vein grafts is not as bad as it was thought to be, 50 years ago. There are new vein preservation solutions. Now we store our veins in heparin and normal saline that damages the vein. So now we are getting buffered solutions. Even on veins, you have got a lot of studies now that show that if you take a vein harvested with no touch technique, it is far superior. The patency is as good as a mammary. See, the veins perform badly, not because they are bad, but because they are handled inappropriately. I mean, you go and see in your own practice today, whenever you harvest a vein or whenever the PA harvests a vein, the first thing they do is to put a bulldog at one end and distend it with all their might. And you have just destroyed that vein. And even after destroying the vein works pretty well. That is how tolerant it is. So a lot of research needs to go into improving venous conduits. A lot of research goes into defining where we should be using arteries. And this is already happening. Now, coming to minimally invasive and hybrid techniques, I think it is good, but it is also a bit of a knee-jerk reaction. It is to a certain extent that, it is more to counter the argument of PCI saying that we only need a small cut. Now we are saying that we only need a small cut in the chest to do the operation. If you can replicate the same results with that small cut, it's fine. If you cannot replicate, if your conduits are suboptimal, if your grafting is suboptimal, if you are grafting the wrong vessels at the wrong areas, it is not serving the purpose. People do not undergo CABG for cosmesis. They undergo CABG so that they can live. So that's my view on it. I think I've covered most of the things that you asked. If I haven't, then please ask me again. I'll try and answer them.
Yes, sir. That should be it.
I like the last comment, Pradeep. That long-term benefit is more important than cosmesis.
Absolutely, sir. And that is, we are falling prey to the same thing. And I don't think it is science. It is market forces.
Absolutely.
So we are indulging more and more in minimally invasive, and there is a wave. And there are some very good surgeons who keep on presenting their techniques to the younger surgeons, and the younger surgeons are misguided into thinking that it's a technique that anybody can do and it has got great results. The problem is there are no angiographic patency results published from India at all. Not a single Indian surgeon doing minimally invasive or hybrid has produced patency rates on any of their patients. So we really don't know if it is a good procedure or a bad procedure. All we know is the patient gets a small scar. And I'm sure we all have our own stories. I know some horror stories that I can share with minimally invasive techniques which have gone wrong. So I think it's important not to lose focus. Like it's what we are doing is if we can't beat you, we'll join you. That is what we are doing with PCI. That should not be our objective.
Rahul has
So,
got a question to ask. Rahul?
So this is exactly, good morning, sir. A very
Morning.
nice topic to discuss on a very rainy day. But anyway, uh, very important point. I like the way Dr. Pradeep mentioned about how we are running behind, doing things just for the sake of it. And this is exactly where I had a big problem with the concept of hybrid coronary revascularization, where again we are trying to appease the fellows and trying to get the patients. I think we should stand firm wherein we should do what is required for the patient rather than trying to do something, a half a job and then giving the patient to them to put in a stent and all that. So I'm very glad this was brought up like this, and like what Shri Krishna sir said, the last comment what Dr. Pradeep said was really nice. We are doing CABGs so that the patient can live, comfortably rather than for cosmesis. Thank you, sir.
Yeah, I agree with you. And hybrid CABGs. See, I've had the opportunity to work with somebody who did the first hybrid case in the world, and that was done about 25 years ago, more than 25 years ago. And I spoke to him recently, and he said it's a bad operation. If you read about hybrid revascularization, you'll find that it was published in Lancet some 25, 30 years ago. And I'll tell you what true hybrid is, what is happening in the name of hybrid. You start a minimally invasive procedure and you cannot graft all the coronaries. So you leave the one that you cannot and you send the patient to have a stent and you say it was hybrid. It was not hybrid. It was failure of the minimally invasive technique. And if you think about it, the patient has got a stent. Why couldn't this patient just have an open surgery and you could have put an arterial graft there? Rather than doing a minimally invasive technique and giving them one graft, you could have just opened the sternum and put 2 or 3 arterial grafts if you were really wanted to do good for the patient. So hybrid has got a role, in my